And welcome to the Dr. Bob Show. You know, almost everybody has had abdominal pain, belly aches at some time. But do you know if it's serious? Do you know what the symptoms of appendicitis are? Do you know what the symptoms of diverticulitis are? Do you know what goes on with chronic gallbladder disease? Do you know if a stomach ulcer perforates, what the stomach would be like, what it would feel like, what your symptoms would be like? Do you know if the small bowel twists and you get obstruction in the GI tract? Do you know what that's like? You know, those are serious things that could lead to death if the diagnosis is not proper. We'll be spending most of the show talking about that. My guest is Dr. Brian Daley. Dr. Daley is a board-certified surgeon. He is a professor at the University of Tennessee Medical Center, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about those over-the-counter pain medications. If it's over-the-counter, they shouldn't be dangerous, but they can be. And new cholesterol guidelines on the diet. Maybe we'll be eating eggs and shrimp and lobster again. Wouldn't that be great? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Brian Daley, professor at surgery in the University of Tennessee. And Brian, welcome to the Dr. Bob Show.
Well, thank you.
Tell me about your training in general surgery. What does a surgeon have to do?
Well, I trained at Tulane University and then an affiliate of Columbia up in upstate New York. General surgery training is 5 years of training. It's of progressive responsibility, learning how to treat surgical diseases.
Wow, that's a lot more training than you have to do in just internal medicine. So it's terribly important. Let's talk about appendicitis. What's appendicitis like?
Well, appendicitis is inflammation of the appendix. That's a tiny little knuckle that sits off the end of the large intestine. It's very common. About 1 in 6 people will develop appendicitis in their lifetime. For most people, it's a surgical disease. That means they require an operation to treat it.
And what are the symptoms like, and where is the appendix located, and why? Tell me about the symptoms.
Well, people generally don't feel well. They kind of have just a dull belly ache. It then moves down to the right side of their abdomen, kind of right above their hip. And then it becomes progressively worse. They oftentimes will develop fever and other GI problems like diarrhea or nausea or vomiting.
So it's the right lower quadrant. When you examine the patient, what are you looking for? What's it like? What's it feel like when it's down there?
Well, I use the one finger test. If you press there and it hurts severely, so much so that the patient jumps off the bed, we call that rebound tenderness, then that's my diagnosis for appendicitis.
Is there a rebound pain? If you push over on the other side and let up and the pain goes to the right?
That's another one of the tests we do. Sometimes we'll move people's legs. Sometimes we'll even just bump the bed gently.
Wow.
Because we don't want to hurt the patient too severely. But that helps us make the diagnosis.
So when you've made the diagnosis, and very briefly, what's the surgery like? Do you have to make an incision down there, or do you do it differently now?
Well, we do it differently now because the surgeon now has a different approach. Instead of making an incision, we use the laparoscope, which means small incisions. We pass a telescope with a camera on the end and are able to do it by passing our instruments through smaller incisions in the skin.
So with the laparoscope, can you take out the appendix and sew it up and do everything that with the laparoscope?
Well, we have some marvelous devices, stapling devices, and then what we call energy devices. Energy is transferred to stop bleeding, sometimes even to divide tissue. So we're able to do everything through the laparoscope. And the patient has minor scars and generally does even just a little better than somebody who has a big incision.
Now, how long are people out when they have that surgery? Can they go back to work a month later or a week later? Or?
Well, it depends on the extent of the appendicitis. For simple appendicitis, most of those people are not even in the hospital 24 hours today. And they'll go home and they'll generally tell us that they're better. Now, some people can develop an abscess, which may complicate their course. Some people may present already with a hole in the appendix. In that case, their course is sometimes a little different, and they may be out quite some time.
So let's right lower quadrant. Let's go to the left lower quadrant. What do you find in the lower part of the belly on the left that's in the abdomen that causes a surgical emergency?
Well, the sigmoid colon, the S-shaped part of the colon where it makes a turn from the inside down to the rectum, is there. And we as Americans don't eat a lot of fiber in our diet. We develop little air bubbles or pouches on the colon. They will perforate, and we call that diverticulitis. And that can be treated with antibiotics, or sometimes it can be severe, and then we need to talk about surgical options.
What's it feel like when somebody's got diverticulitis? It's inflammation down there, they have a fever, bloody stools, what's the exam like?
Well, for diverticulitis, they will have oftentimes a low-grade fever to a high fever, and then it feels like appendicitis on the left side. They oftentimes will have rebound tenderness. And we kind of grade it on a scale of 1 to 4, whereas 1 can be treated as an outpatient, whereas 4 is a surgical emergency.
If somebody has diverticulitis and you're comparing on the left side to appendicitis on the right, do you have to remove part of the colon with that, or can you usually treat it with medicines?
Usually we're able to treat it with antibiotics and a change in the diet, that is increased fiber in the diet. But there are times when we have to do an operation. We always like to try and get the patient much better. That just gives them a better opportunity to have their surgery and have what we call a primary anastomosis. That's where we hook the bowel up together and we don't have to bring the bowel out onto the skin.
So it really advances knowing what to do as far as that goes. How long is the patient out with diverticulitis?
Well, it depends on their clinical course. Oftentimes they'll spend a few days in the hospital and then be converted to antibiotics by mouth. Those antibiotics will generally continue for about a week, and then hopefully they're better. The goal is to get the patient so we can do an operation laparoscopically if they're that sick.
So you can take out the colon, part of the colon, laparoscopically. How much do you normally have to take out?
Well, I would say it's usually about 18 inches.
So, well, that's a lot, 1.5 foot, and you can do that laparoscopically. So we've got appendicitis, we've got diverticulitis. So that's right lower quadrant, left lower quadrant. Tell me about the right upper quadrant. What problems do you get there?
Well, the gallbladder sits in the right upper quadrant. And in East Tennessee, that's a very frequent problem. That's just based upon the heritage of the people who live here. The gallbladder stores digestive juice your liver makes, and as it stores it, it takes out water, and that makes gallstones. And they can irritate the gallbladder, they can block off the gallbladder, they can even block off the liver.
So what are the symptoms like if somebody's got gallbladder disease?
Well, the gallbladder squeezes and releases its juice when people generally eat a fatty meal. So they will have pain a couple hours after they eat. It'll be in the right upper quadrant, may go to their shoulder or right between their shoulder blades.
So even though the gallbladder lies in the abdomen, it will send pain, radiate pain up in the shoulder sometimes. Is there any characteristic findings on physical exam? How tender is the abdomen? What do you feel for?
Well, as a good Irishman, we always enjoy what we call the Murphy sign. And that's where if you press on the right side of the abdomen, right under the rib cage, and the patient takes a breath and pushes down, they jump when you hit the gallbladder.
Is that a pretty good sign, Murphy's sign?
That's a very good sign.
And when they've got that, then do you have to get other studies before you do the surgery? It depends on how hot it is. How do you know if it's an emergency or not?
Well, the other problems the patient will have, like fever, like blood pressure problems, sometimes they may even be jaundiced or turn yellow. We oftentimes will use ultrasound to help us decide what's best to do. Cholecystectomy, we can do that laparoscopically as well.
So back in the old days, the scar was almost across the entire upper part of the abdomen. Now how many punch holes do you do?
Well, there are people who can use just one punch hole by the belly button.
Wow.
Most surgeons will use 4 punch holes, about 1 inch by the belly button, and then 3/4 inches across the right side of the rib cage.
When you're doing a laparoscopic surgery, taking out the gallbladder, tell me about putting air in there and then going after and attacking. Why do you put air inside the abdomen?
Well, we need space to be able to see and work. So we insufflate with a gas that's not flammable. So we use carbon dioxide. Your body makes carbon dioxide so your body can get rid of it. So we insufflate or fill up the abdomen with gas. That gives us ability to see and separate the organs. and then we can do the procedure just, again, using a telescope on a camera and passing our instruments through those small incisions.
Is it hard to go in there and find the gallbladder? It's laying under the liver, but it's, you know, you have to know where you're looking.
That's why we do it, we go to school for so long.
How long is the patient out of work if you do laparoscopic cholecystectomy, take out the gallbladder?
Well, for people who just have problems, what we would call biliary colic, it's a day surgery. They come in the morning, have the operation, go home the same day, and most people by a week are back to doing everything they want to.
If somebody has a ruptured ulcer in the stomach, is it hard to diagnose?
No, it's not very hard.
And that's what we're going to be talking about. It would be hard for me if somebody's got a ruptured ulcer in the stomach. What is it like? What symptoms do you have, and how do you know it's an emergency or not? You'll want to stay tuned. We'll come back and talk about that. We're talking with Dr. Brian Daley, board-certified general surgeon, professor in the Department of Surgery at the University of Tennessee Medical Center. We've been talking about problems with appendicitis, right lower quadrant, diverticulitis, left lower quadrant, gallbladder disease in the right upper. And then we talked about how do you know if something's perforated? Stomach ulcer, heartburn, acid indigestion, gnawing pain. If it perforates, what's that like in the emergency room or before you get the patient on the table?
Well, it's severe pain. It's so severe that it causes a reaction in the muscles of the body that they contract and protect the abdomen. So we call that involuntary garden.
So involuntary, that means the patient doesn't have anything to do with it. So they come in, what's the belly like when you feel it?
Well, we call it a rigid abdomen. That the muscles are so tight that you can't press down to elicit the pain that we would do, like we talked about rebound. But even coming in, riding in the ambulance or the car, any little bump causes severe pain.
So how do you know, you have an idea that it's a ruptured something in the GI tract? How do you know it's stomach by history? How do you know it's not a ruptured appendix or a ruptured intestine? How do you know that?
Well, our main decision is to try to decide how and when to operate. So if somebody has that severe pain, we know something is really wrong.
Big bad.
And we're going to operate regardless. And then that way we used to call it a Bard-Parker scan. They made the scalpels. Nowadays oftentimes we use a laparoscope. So that's the exploratory laparotomy. We want to look inside and see.
How good a vision can you, we've talked about going in isolated areas. How good can you do looking inside the whole abdomen with a laparoscope? That seems amazing to me.
Well, our experience with laparoscopic cholecystectomy is now over 25 years. So this is something that virtually every surgeon has trained with and learned. In addition, the technique has been used now and extended to virtually every abdominal operation that a surgeon does.
So if somebody's got a perforated stomach ulcer and you're not sure where it was, when you go in, you've got to look all over everywhere. Is it pretty easy to figure out, is there a key to when you look in what's going on?
Well, in general, for perforated stomach ulcers or duodenal ulcers, we have a clue because we'll get an x-ray and it'll show air in the abdomen. That's about 85% accurate. For other people, we know that there may be air in there and it may come from somewhere else, and that's when we'll have to go look.
So when you do the laparoscopic examination there, what do you do with the perforated stomach ulcer? Can you suture it up? What do you do?
Well, in general, we take a part of the abdomen, we call it the policeman of the abdomen, the omentum, and we cover that because we know what causes the ulcer. It's usually hyperacidity, so we'll treat them for hyperacidity. It's a growth of a bacteria called Heliobacter pylori, so we treat them for that, and then we get them to avoid other bad behaviors. We wash out the abdomen and let the body heal that ulcer without more provocative events.
Why do you wash out the abdomen?
Well, the abdominal contents have spilled into the abdomen, and that may lead to an abscess or a collection of fluid.
So how do you wash it out? Do you just put in saline, a special stuff? How much do you put in? If you put it in, how do you get it out?
Well, the devices that we have with the laparoscope include suction devices and irrigation devices, and we will generally irrigate until we see clear fluid coming out. And we can do that virtually in all the spaces in the abdomen.
So any kind of perforation you can do that with. Tell me about, let's switch over. Let's go to Obstruction. If somebody's got bowel obstruction, how do you figure out where it is and how do you fix it?
Well, in generally, we listen to what the patient has told us, and they'll have crampy abdominal pain, and then they won't be able to pass gas or stool from below. They'll oftentimes vomit, and that type of vomitus they have, whether it's green, like bile, sometimes it can be very dark, like stool, that will tell us basically in what location that obstruction is.
When you're examining the abdomen, if they've got obstruction, what's it like when you examine?
Well, they're bloated, and that's usually their complaint. Their abdomen is bigger, and sometimes if they have tenderness, that would be more an indication for me as a surgeon that we need to intervene early. Oftentimes we just watch these people and let the scarring that's happened settle down and extract the fluid in a very uncomfortable way with a tube down their nose into their stomach to evacuate those.
Yeah, but sometimes those tubes are lifesavers in their own self. Tell me, what does the x-ray look like if you've got an obstruction and you've got a bloated belly, a big belly, a pregnant-looking belly?
Well, we'll see gas in more than we expect in the intestine. And we may even see fluid levels, we call them air fluid levels, and sometimes they'll be in a stair-step pattern. So you can see that each of those loops of your intestine is not moving the normal contents through, and there's air and fluid in there.
What are some of the causes that you have to fix surgically of somebody that's got obstruction?
Well, the most common cause is somebody who has had surgery before. Just like our skin heals when we cut it, when we do an operation, we leave behind scar tissue. That's the most common cause.
How does the scar tissue cause blockage of the obstruction?
Well, the intestines in the abdomen move all the time. It's their job is to push fluid backwards and forwards so you can digest and absorb. When that scar tissue forms a fixed point, the bowel may twist about that. It may pinch it off so that we have to relieve that obstruction.
So that would be more difficult, less difficult? You go and find what the area is and then you just remove the scarring and hope that it doesn't scar again? Is that pretty much it?
Well, it's an unfortunate consequence, and any operation will lead to scarring. And as a surgeon, we have to relieve one scarring, but we may create more scarring, and it can be a chronic problem for some people.
When you've got blockage, could that be secondary to a tumor that's there is blocking? And tell me about intussusception. That's a big long word. What does it mean?
Well, the most common cause of scar tissue next would be tumors, and our biggest worry is colon cancer. So that's why we encourage everyone to get a colonoscopy when they turn 50. Next, things like hernias, where the bowel can get pinched in a small little defect in the abdominal wall. And then, of course, there are other things like intussusception, and that usually involves an area of inflammation in the intestine, and then the bowel telescopes over.
So it goes right inside itself.
Goes right inside. And for the adult, that's worrisome not only for bowel obstruction, but what has caused that to happen.
So when you go in and you do surgery and you see where the bowel is intussuscepted right there, you pull it out and then you have to figure out what caused it, or do you have to remove that part of the bowel because it's weak, or what?
We have to remove that part of the bowel. For children, we can often open that up with just some gentle pressure, generally through either an enema, which is fluid up the rectum.
Back.
But for adults, in general, we can't. And we worry about the blood supply that goes to the bowel. And of course, what's caused this intussusception.
And when you talk about blood supply, if you lose the blood supply to the omentum or the mesentery, that causes a non-surgical pain. Is that non-surgical abdominal pain or what?
Well, that's like gangrene anywhere.
Yes.
And our bodies don't tolerate gangrene. So that's a surgical condition. Unique to that is that oftentimes they won't develop the inflammation of the peritoneum, but they'll have exquisite pain. And the hallmark of that bowel ischemia is pain out of proportion to physical exam.
Brian Daley, I enjoy listening to you talk about these surgical emergencies and how you can organize your thinking and go in and find it, help people. It must be really a great feeling when somebody comes in about ready to die and they walk out 2 or 3 days later saying, I'm ready to go play golf or do my normal activities. Thank you for coming to the Dr. Bob Show. You're a great teacher.
Thank you.
If you've got abdominal pain and it's worse than you've ever had and it persists and you've got fever or other symptoms we talked about, be sure that you go to the emergency room and get proper treatment for that. The surgery is so good now, and you can walk in today and walk out very shortly thereafter, being able to do normal activities. And now you're going to want to stay tuned. We're going to come back and we're going to talk about over-the-counter pain medications. They shouldn't be dangerous, but they could be. And if we have time, we'll be talking about new cholesterol guidelines that may allow you and I to eat eggs and shrimp and lobster. A lot of information for you. I want to thank Dr. Brian Daley. Wonderful discussion on a surgical abdomen when it's an emergency. I hope you enjoyed it as much as I did. Now, questions from you, the viewer, that I think will be important to your health. Dr. Bob, when I go to the drugstore looking for pain medication, I'm overwhelmed. What medicine is best if I've got a simple headache? Well, let's think about over-the-counter pain medications, because there are three basic ones. Number one is Tylenol. We call that acetaminophen. Number two are the ibuprofen, Aleve, Advil medications. And number three is simple old aspirin. So let's start off with Tylenol, acetaminophen. It's a good pain medication. It's there for just pain. Doesn't work against inflammation and joint discomfort and swelling, only for pain like a headache. But there's a problem with Tylenol, acetaminophen. If you take too much, it's the leading cause of acute liver failure. More so than viral hepatitis is Tylenol causing liver failure. Well, why could you take too much? Well, if you're taking Tylenol regular for pain, and then you get other medications that have Tylenol in them, let's talk about Excedrin. Excedrin migraine, extra strength Excedrin. All of those have Tylenol and aspirin and caffeine in them. So you'll start taking other medications, and if you got a headache and the dose is 2 and you say, oh, I need 3, and you take 3 and you've been taking it regular, you're setting yourself up for acute liver failure, especially if you're using more than 2 drinks of alcohol a day. So be careful of Tylenol. That's number one. Number two, let's go to ibuprofen and Aleve. Good medications. They work against inflammation. So knee pain and joint pain, and anything that has inflammation with it, arthritis of any kind. So they're good, but they are a leading cause of GI bleeding, of stomach ulcers, of duodenal ulcers. So if you take those medicines, ibuprofen and Aleve, then you have to be careful. If you take them regular, then you've got a good chance, about 9% chance of getting a significant GI bleed. Not only do they cause irritation of the stomach, but they also can cause high blood pressure, and they affect the kidney tubules, part of the kidney, that make you have that high blood pressure. So know if you're taking those medications, you need to see your doctor. Let's talk about aspirin. You know, an aspirin a day keeps the doctor away. You take an aspirin and it prevents heart attacks and strokes. Well, now what we do is we say the following. If you've had a heart attack, we know a baby aspirin is good for you. But you may have to have the problems of an aspirin. You may get some GI bleeding. If you've had a heart attack, baby aspirin will help you on a daily basis. If you've never had a heart attack and you don't have any risk factors for heart disease, then a baby aspirin, better be careful about that. You probably don't need that. You need to talk that over with your doctor and talk about the pros and cons of a simple baby aspirin, 81 milligrams every day. The more aspirin you take, the more it irritates the stomach, the more chances of your having a GI bleed are. Aspirin's a great medication, but its greatness is because it doesn't let the platelets adhere and doesn't let things clot, so it makes it where you can bleed easier. Be sure that you're not taking that with some other blood thinners or other medications that keep your blood from clotting. Question number 2, Dr. Bob, can you tell me about the new cholesterol guidelines? My next door neighbor told me that I could eat eggs. Well, it gets down to very simple. It doesn't seem to be the high cholesterol foods that are causing the problem. So you can have a couple of eggs a week. You can have some shrimp, you can have some lobster. What we want you to do is cut down on trans fats, on fatty foods, on greasy foods, on fried foods. So read the labels. If you've got saturated fats or trans fats of any significance at all. Stay away from those foods. You can have 2 eggs a week. Go ahead and have shrimp when you want it. Well, that's all the time that we have for this show. I hope you've enjoyed it as much as I have. Remember, we've got to be exercising. If you'll exercise every single day, helps the brain, it helps us relax, it helps blood pressure, it helps us lose weight. Exercise is probably the best of all the things that we talk about. Remember that you need 8 hours of sleep. If you don't get 8 hours of sleep, 7.5 hours of sleep, you may be leading yourself into high blood pressure, heart disease, other problems, and not enough sleep may be the cause of death. Be sure that we're eating properly. Eat fruits and fiber and vegetables. When you look at your plate later on in the day, put two fruits on there, and then you'll use those to fill yourself up. You'll find you'll be eating better. And most of all, what do we like in the Dr. Bob Show? Is that laughter in your life. Remember, find that somebody that you enjoy giggling with and laughing. The more you laugh, the healthier you're going to be, and the world will be better.